very much.
Good afternoon and welcome to this, which is the first in a week-long series of events showcasing some of the exciting projects and developments at the Royal Surrey NHS Foundation Trust. I'm Sue Shuver and I'm Chair of the Trust Board, and I'm delighted to have this opportunity to show you some of the very exciting and interesting developments that there have been at the Trust, particularly since the pandemic has meant that for the last 2 years we haven't been able to link our members' events with our annual members' meeting in September. So it's great to have this opportunity to do this. This is a chance for our members and our partners to really be part of the Royal Surrey family and get involved in some of the things that we're doing together. If you're watching this and you're not yet a member of the Trust, please do consider joining us as a member. You can find details on our website. Becoming a member commits you to nothing and it costs you nothing, but it does give you access to regular updates from the Trust. And if you become more interested and you want to get more involved, you can vote in elections for public and staff governors and can even stand for election as a governor if you wish to do so. So at the end of these presentations, we will have a question and answer session. And if you want to ask some questions or record your questions during the event, you can do so online. Looking at your screen, across the top of the screen, there is a menu bar, and one of the icons in that menu bar is the show conversation icon, which is a little speech bubble. If you click on that, you will see a panel appear on the right-hand side of your screen, and you can type your question into that panel, and when you press send, it will be sent to us and we'll be able to see your question. If we have more questions than we can answer this afternoon, we will type both the questions and the answers into our website, so keep an eye out for that. So the Royal Surrey is not only a regional cancer centre, it's the only hospital in England which has 4 robots capable of performing cancer surgery. It also has one of only 2 ETHOS radiotherapy treatment machines in the UK. And the ETHOS machine is capable of delivering very targeted, sophisticated radiotherapy treatment. Shortly, we'll be going across live to our theatres, where we'll be joining Mr. Matthew Perry, Clinical Director. Matthew will share with us how innovative robots can help our surgeons perform delicate surgery. We will then join Helen Burland, Professional Head of Radiotherapy, and Dr. Charlotte Shelley, Clinical Fellow in Adaptive Radiotherapy. And together they will show us how the new Varian ETHOS treatment machine will work to use state-of-the-art technology to really focus radiotherapy treatment for our cancer patients. But before we join Matthew in theatres, we'd just like to show you a video which shows the impressive Da Vinci robotic surgical system. Thank you.
Good afternoon. Welcome to Theatre 2 here at the Royal Surrey. My name is Matthew Perry and I'm a consultant urological surgeon. And your surgeon will see you now. So this is a Da Vinci robot. Imagine you're needing an operation and imagine this is your tummy. Our robot comes over your body and our instruments are placed inside your body cavity with these ports. What these instruments give us is miniaturization. And so these instruments are tiny when one compares it to the human hand, and they've got amazing rotational and flexibility. It also gives us 3D imaging with this camera system and 10-fold magnification, as you can see on the screen. The instruments are docked and undocked from the machine in such a manner. And when one replaces them, they go back to exactly where they were when you took them out, as an amazing safety feature. But this is not a robot by way of plug it in, program it, and off it goes. It's driven. It's driven by surgeons like me. And here we are with the surgeon consoles, and we have 2 consoles because we do lots of teaching and training here at the Royal Surrey, and we're very proud of that. The surgeon drives those instruments you've just seen. The surgeon's fingers are in these finger cots, and with rotation and movement of the arms, we can put the machines in and out and round, so we can cut and we can stitch with amazing accuracy. The surgeon is comfortably seated, and we'll look through the visual console to look at 3D imaging portrayed through that. Now, with these dual consoles, we do an awful lot of training here at the Royal Surrey, and we probably train, we take a year to train surgeons from all over the world in a particular operation. The operations don't take any longer than a group operation. There's lots of myths about that. They are just as fast, but the main importance is the fact that it's keyhole surgery, it's computerized, and therefore we've got better accuracy in what we do. That means less blood loss, it means less infection, less trauma to your person, and as such, you get up and you recover much, much faster. Here at the Royal Surrey, as Sue was saying, we've got 4 machines. There's one in the operating theatre next door, one here, one in the operating theatre to the other side of me as well, and then the 4th one is a training machine. We do all manner of surgeries here now. When I first came here, it was just prostate and bladder surgery and gynaecological surgery. Now, throat surgery, gullet and stomach surgery, liver, kidney and spleen surgery. So all manner of different operations can be done with these devices. What I'd like to do is take you to some slides to show you a bit more about what we hope the future will bring us with these types of machines.
Hello, you will have gathered that we're having a small technical problem with the sound from theatres at the moment. So what we'd like to do is leave Matt for a moment and just move on to Helen and Charlotte, who are going to take us through some information about the ETHOS machine. And we'll perhaps come back to Matt a little bit later in the presentation. So can I hand it over to Helen at this point?
Welcome and thank you for joining my colleague Dr. Charlotte Shelley and myself, Helen Burland, Head of Radiotherapy here at Royal Surrey. Dr. Shelley and I wanted to share with you an exciting development within the radiotherapy department. In 2019, we had a fantastic opportunity to purchase a new model of radiotherapy machine with the ability to use embedded software that uses artificial intelligence to improve treatment delivery for patients. To explain this, allow me to give a little background to radiotherapy treatment and how it's developed over the years. Radiotherapy is the use of radiation beams to treat cancer. Because every person and every cancer is different shape and size, we need to personalise how we deliver treatment. We use scans to map out the tumour and a small area around it to create a treatment plan. We want to give this as much radiation dose to the area that is safe to do. We also want to limit the amount of radiotherapy to the tissue received nearby to reduce the side effects. We work with a high level of precision, but with movement inside the body, such as breathing or bladder filling, or changes in the tumour itself during treatment, this can make this a really tricky ask. Technology along the years have introduced new ways of managing these movements or changes, and we can now better use images to check a patient's position is matched to their treatment plan. However, there is still a limit to the level of correction that can be made and how we respond to this. The ideal scenario is to correct the treatment plan to real-life anatomy of the patient's tumour position prior to treatment delivery every day. The ETHOS machine provides us the ability to do this. Dr. Shelley will now explain a little more in detail how this works.
Hello, my name is Charlotte Shelley. Thank you for giving me this opportunity to talk you through a bit more of the clinical side of what we are currently delivering at the Royal Surrey with our ETHOS machine. As Sue explained, we are only the second centre in the UK to have an ETHOS machine, and this opportunity arose a few years ago. And since August last year, it has been in place, and since only in January of this year, we've been treating patients with very state-of-the-art technology. As Helen just explained, when we treat a patient with radiotherapy, in the curative setting, this is normally delivered over a 5 or 6 week period. The patient will attend for a radiotherapy planning scan a few weeks before they start their treatment. And not only do we need to make sure that we treat that target every day, we also need to treat a safety margin around that to encompass the movement of the tumour within the patient's body. To be able to do this with more precision, the ETHOS machine allows us to scan the patient every day, and using artificial intelligence, it contours the area that we want to treat and also the areas that we want to avoid. With much faster computers, we are now able to recreate a new radiotherapy plan which we can deliver to that patient on a daily basis. This was unimaginable only 5 years ago. We have now, since January of this year, treated 12 patients with daily adaptive radiotherapy. We have started treating patients in the pelvic area, including cervix and bladder patients. As for those patients, there is a much larger movement and a safety margin that we need to apply to ensure that the tumour is treated. As you can see on this slide, there are 6 images. On the right-hand side, the images are CT scans that a patient would have taken a few weeks before their treatment starts. As you can see, I hope, there is a dark red line, which is the target that we need to treat every single day. And the colour wash, the colour around that red line inside it, is the dose that we need to deliver to our target on a daily basis to cure that cancer. The 3 images on the left-hand side, as you look at the screen, are images taken from one of our patients we have recently treated on the ETHOS machine towards the end of her treatment. As you can see, the red line has shrunk in size as the tumour has shrunk during her treatment. And what you can now see is that the area that we would have treated is much larger than what we were able to deliver to that patient on that day. So not only are we managing to make sure that we treat our target every day, but are also able to reduce the dose to the bladder towards the bottom of the image and the bowel up at the top, which will therefore reduce the patient's long-term side effects following their radiotherapy. We have had feedback from our patients who have been receiving this treatment, and so far they have been very happy with the service that they have been receiving. Not only is the machine quieter than our normal machine, but also you do not see the inbuilt anatomy of the radiotherapy machine and the noise that creates. There is also another highlight of this, that in our new radiotherapy machine, we have a skylight, which the patients also find very effective to distract them during the course of their treatment. Thank you so much for giving me this opportunity, and I'll now lead on to a video of Sandy, one of our first patients who was treated with this machine. And on the video, you can very clearly see the skylight in the middle of the video. Thank you.
I've got stage 3 cervical cancer in my cervix. My tumour's 8 centimetres. Well, it was when we first started this. Obviously, I'll get my results from my MRI and afterwards to see if the treatment's been working. They said, look, you don't have to come here, but it would really benefit you. It's a new machine. Obviously, it's been approved, but it's so new. Would you be willing? And I was like, absolutely. This has been absolutely amazing. Every day that I come in, I get scanned to see how my bowels are, and then the program goes online, and then my treatment gets adapted to how my insides are, so then it targets the place where it can do. I'm really apprehensive, obviously, first starting out, because obviously when you first get your diagnosis, you're not sure on anything really. You're really nervous, you feel quite vulnerable, but the team here have just been absolutely fantastic. Like, they've held my hand from the moment I got here, and I haven't found it as stressful as I thought I would. I'm more than grateful. It's going to hopefully save my life.
Thank you very much for that, Helen, Charlotte and Sandy. Now we have got Mr. Matthew Perry back. He's come to join us and talk to you a little further about the robotic surgery that he was explaining earlier. Matt.
Thank you very much. Sorry about that. Just run all the way across the hospital to finish this short presentation. So the machine you saw downstairs has been used millions of times over the world, and the expansion in surgery across the world has been pretty much replicated here at the Royal Surrey. So the graph will show that robotic surgery over the last 10 years has really taken off. With pelvic surgery, what I do, prostate and bladder surgery, as well as gynaecological surgery, real being the trailblazers. But now other surgeries are starting to take over, so oral surgery, as well as pancreatic and liver surgery. And the Royal Surrey has again adopted all of these different types of robotic assisted surgeries as well. So there's been a slight decrease, as you can see on our curves there, but of course we've had COVID as a global pandemic to deal with. Robotic surgery growth here in the UK and in the Royal Surrey in particular is going to continue to change. We've come a long way. So when I started back in 2007, the machines we used were the Da Vinci ones. These were pretty cumbersome things, they actually came out of Ronald Reagan's space program from the 1980s. And was developed from all that money pumped into the Star Wars program back in the day. We've progressed and we've got Da Vinci Xis here now. And what these new platforms give us is the ability to change and develop into the future. So you've just seen the ETHOS machine and how it superimposes radiotherapy over the target. Well, we should be able to superimpose a tumour over the vision that we can see when the surgeon looks down the visual console. And so we'll be able to more accurately dissect out and remove that tumour and leave all the healthy tissue behind. The very beginning showed a technique called single port surgery. So at the moment we make 5 or 6 cuts across your tummy to put all of our instruments in. With the new one, it'll be a single port machine where all the instruments go in and start to fan out. And that's what you were seeing in that early video, which will be an amazing advantage with regard to wound healing and lack of infection and things like that. I think now we'd like to cut to one of our patients who has been through our service and has had surgery using these devices over the past year or so. So here is Mr. Peter Clark.
Well, in August, beginning of August last year, we noticed some blood in my urine. So I reported this to my doctor, who immediately took some urine samples. They showed up some pretty bad results, so I was immediately referred to the Royal Surrey. I was booked in for an overnight procedure to basically examine the bladder, and that showed up some worrying results, and it was decided that I should have my bladder removed, which took place on the 12th of March and was a great success. I was in hospital for 5 days, and since then I've been gradually recovering and getting used to the fact that I no longer have a bladder. I was very pleased it was an option. It was much less invasive. I was told that instead of losing a fair amount of blood, I would lose at most 200 millilitres. And it leaves, robotic surgery leaves very little scarring. I know where the 6 entry points are, but other people might find them quite hard to find. I mean, I think it's absolutely fantastic. The fact that the surgeons can see your insides 10 times magnification means, you know, you think that it's going to be so much more precise. The recovery was much quicker, and of course this time being in COVID, it meant I couldn't have any visitors, which obviously doesn't help you when you're in hospital. So it's quite good that I was able to get back to my wife a lot quicker.
Thank you to Matthew and to Peter. So now we have time for some questions, and I have a few questions that have already been submitted. The first one, which I think is probably a question for Charlotte, is how are patients selected to be candidates for ETHOS treatment?
Thank you. At the moment, we're treating patients with tumours in the pelvis, so patients with cervix cancer or bladder cancer. And the reason for that is because they inherently move quite a lot, so they're perfect targets for daily adaptive radiotherapy. So that's where we're starting off. At the moment, each patient has a considerable extra amount of time dedicated to them, just while we become more familiar with the technology. Hopefully, as time goes on, we'll be able to expand to other treatment sites as well.
Thank you very much, Charlotte. I hope we're not making you dizzy by moving around, but we are maintaining a social distance, but also keeping masks off so that those of you who have hearing difficulties can lip read if you need to. So that just explains what we're up to here. So a second question, which I think perhaps is a question for Helen, is as the system's software is very complex, has this been affected by lockdown and engineering support not being available? And what's the contingency plan for the future if there are problems?
Thank you for the question. When we came to install the machine, we were mid-COVID pandemic, so that came across with some challenges. So we needed to think how we could install the machine and commission the machine safely. What we had was a lot of remote access from our engineers. So the great thing with technology is that we're allowing engineers to be able to remotely access into the machine, to be able to look at faults and install those machines. So that gives us very fast access to engineer cover if we need that. We found that as we move forward, that we will create a conventional treatment plan so that if there was a situation where the machine wasn't working, we would have capacity to be able to see the patient on a different machine. But those patients have successfully had their treatment. So we have engineers on site available to us, and we work very closely with the manufacturers so that we can monitor the performance of the machine. Thank you.
Thank you very much, Helen. So I think I've got one more question for Charlotte and then perhaps a few questions for Matthew. So Charlotte, what type of training is required to deliver this kind of radiotherapy treatment?
As I said, this is very new for all of us. And so we have developed an in-house training programme, and not only for doctors, but also thinking for the future about how we think this service is going to be able to be run. As I said, it's quite resource intensive at the moment with a lot of clinician involvement, but we hope that in the future we'll be able to train up our radiographers to be able to deliver this treatment. We have already signed off a few of our radiographers to deliver bladder treatments independently, and that's a really exciting place for us to be in. And we hope as we develop further and can treat more sites, that training will need to obviously develop alongside it. So I hope that's answered the question.
Thank you, Charlotte. So a question about robotic surgery for Matthew. How do people react to this type of surgery? And have you found it particularly challenging with older patients embracing the new technology?
I don't think I've come across anybody who has said they don't want to have this operation, have an operation in this manner. And I think that the benefits of keyhole surgery are so well known now that actually I think everybody embraces it, and I don't think it matters what age they are. I think when we first started robotic surgery, and for me that journey started in about 2007, 2008, it was virtually unheard of, and so we had to tell our patients, you're the first one, and that wasn't a problem for the patient, and so no, I think everybody's embraced it as far as I can see. I think the main stick in the mud is perhaps us as doctors.
Thank you. So a couple of questions about you as doctors. Somebody has asked, how long did it take you to master the skills of robotic surgery? You were saying earlier that it takes you about a year to train somebody, but presumably you were quite a pioneer when you started doing it.
So that's quite right. The training programs now are really nicely defined with steps along the way. When a lot of us were training when these machines first started to appear in the UK, it was a bit like the Wild West in training and how you would master the machine. So the operations, we all knew how to do the operations with our hands and our instruments, but the interfacing of the man and the machine and then the patient was more difficult. So in general, we were doing fewer operations robotically then than we're doing now. And in fact, if you do a lot all at once, actually you pick up the skills really rather quickly. So now, whereas it took me maybe 1.5 to 2 years to master some of the skills, now we'll take somebody fresh and really train them up within 12 months to be an excellent surgeon.
Thank you very much, Matthew. So just one more for you, and then I think I've got a question that any of our three clinicians could answer. How did you actually start your career in robotic surgery? What drew you into it?
I've been doing prostate and bladder cancer surgery for a number of years, both as a trainee and then as a consultant. The future was becoming obvious with the growth of keyhole surgery, laparoscopic surgery, and that's been used for gallbladders and hernias for decades already. So it was obvious it was going to come into some of the more technically challenging surgical procedures. And then when these machines came along and actually showed us how much easier it could be with better vision and different instrumentation, it was just the obvious next step. So a lot of us in urology and gynaecology in particular, where the pelvis can be a difficult site to get to, we jumped on the bandwagon, and we were very early adopters in this kind of technology.
Thank you. And this is a question, I'm not sure whether this is aimed at Charlotte to do with the radiotherapy treatment or Matthew to do with surgery, but perhaps you'd both like to have a go at it. What happens if there's a sudden power outage? What do you do then?
We have a go. Yeah. Well, we haven't had that problem yet. We have had other problems, floods, but we would have an issue with all of our machines if that were the case. So we are very heavily linked in with all of the IT support in the radiotherapy department, as I'm sure the surgeons are as well. What we have noticed, especially with this technology, is because it's a cloud-based technology, we have run into more problems along with network issues and requiring quite heavy IT support. But also, as this is so new, we're all just finding our feet with it. But to answer that question, if there was a power outage, all of our machines would have a struggle, and we'd have backup plans and have to rearrange for the patients to have their treatment.
Shall I come over?
I think you can stay where you are, actually, Matthew, and we'll switch the camera to you.
So the robotic machines that we use have a battery pack inside them. The theatres have their own independent generator. So if there is an outage, we can continue to work, although if there is a major problem with power, then we will often revert to old-fashioned surgery. When I say often, I think it's happened once in the history of this hospital.
Thank you, Matthew. And I think you may have touched on this already, but someone has asked what other types of operations are done with robots.
So I think one of the ones that's been pioneered here is oral surgery. You can put the robot down the mouth directly and then start to remove cancer in the tonsils and in the throat here. And that can be a huge advance because sometimes to get to these areas you have to open up the jaw, and that requires the jaw to be then wired back together again. So decreasing all of these extra steps that has to be taken. We're also doing esophageal or gullet surgery to remove cancers in the gullet and bring the stomach up into the chest to join the space where the tumour's been taken away from the gullet. Liver surgery lends itself perfectly to robotic surgery as well, to remove areas of the liver with tumours in them. So the uses are far and wide.
Thank you, Matthew. And at the moment, I just have one other question. which I think perhaps Charlotte and Natalie would both like to have a little go at, and that's speculating about the future. Do you think there is a possibility that robots might replace humans in jobs in healthcare in the future? Do you want to start on that, Matthew?
Yes, I do. It's one of my favourite topics. I don't think robots will replace us. I think they will assist us. So the huge number of patients we have to see, the huge volume of scans we have to read every week, the samples of tissue that we have to analyse every day of every week, a lot of these different processes can be done by machines and robots. General anaesthetics may be delivered using robotic oversight with humans overseeing perhaps a number of theatres. So I don't think we will have a decrease in the number of people. I just think our productivity will increase. And we've seen that in many industries over the world.
I would agree with what Matt has just said. Certainly from a radiotherapy point of view, there are more parts of the treatment course which are now being automated. For example, contouring lots of organs prior to delivering radiotherapy. There are already many tools that are being used to do that automatically. However, they still need oversight, and especially with our ETHOS machine, we've seen that although it depends very heavily on the artificial intelligence to put contours on, these still need to be verified and clinical decisions need to be made in a very quick amount of time. So I can't see them taking over jobs yet. I hope that they'll be able to facilitate doing aspects of our job which can be machine learned.
Thank you, Charlotte. So that prompted a few more questions from those of you who are watching the presentation. So perhaps I could start with this one. In the near future, will it be possible to use robotic machines for an esophagectomy? Is that one for you, perhaps, Matthew?
We already are using those machines to do exactly that. So an esophagectomy is a removal of the esophagus. That's the gullet, so we swallow and it goes down the esophagus into the stomach. So we've already started to use the machine that we showed you in the theatre for that operation. Now, it's not a robot that is a programmable thing. It's driven by us, as I was showing you. So I guess the short answer is yes, we've already started to do it.
Okay, thank you. And somebody wants to know, is robotic surgery more difficult for you as a surgeon than traditional surgery?
No. If I had the choice, I would dock the robot for every operation that I do, because I find that is the best tool for me to use. Having said that, sometimes it's the wrong tool and we have to take it away and go back to the old-fashioned techniques and the old style of surgery. So I think our ethos, to steal somebody else's phrase, would be to say that you've got to use the right tool for the right operation, and occasionally the robot will not be the right tool.
Thank you, Matthew. And a question relating to the patient video of Peter. Somebody is asking, how is it possible for one to urinate without a bladder?
That's a very good question. So we do two things generally here at the Royal Surrey. We take about 15 centimetres of your guts. One end we bring out onto your tummy wall, one end we leave on the inside, and we plumb your kidneys into that. And so urine comes out through the tube into a bag on your tummy wall. That's about here. The other thing we do is take about 50 centimetres of your guts, open it up, fold it into a ball, and put it back into your pelvis and plumb your kidneys into that. And that's called a neobladder. It's not really a bladder, it's just a receptacle for storing urine, and you have to kind of learn how to pee again. But those are the two main ways of doing a urine diversion. And they're both well accepted.
Thank you very much. And then perhaps a question for Helen or Charlotte. Are there any types of cancers treated with an ETHOS machine, or are only certain ones able to be treated? Sorry, I don't hear it very well. Can you treat any type of cancer with an ETHOS machine, or are there only certain types of cancers that you can treat in that way?
So at the moment we are concentrating on tumours in the pelvis. There are, I think, around about 40 of these machines globally, and other centres are treating other sites. There are certain new aspects of the machine as it's being advanced that would be required to treat other areas such as the lung. So for treating a lung cancer, you need to have some motion management so that you can see how the tumour moves with breathing. At the moment, we don't have that, so we are treating areas in the pelvis, but other sites in the UK are treating head and neck patients, and also tumours of the upper GI, so pancreas. They're also treating other sites. So technically it could be used for most sites. The concept of daily adaptive radiotherapy is just to be able to deliver more accurately based on imaging. And with what we're able to do is you can have that imaging in a new plan on a daily basis. So to answer the question, yes, I can see it being rolled out into many other sites.
Thank you, Charlotte. And a couple of questions that I'm going to ask Helen to address here. The first is, does the use of ETHOS have lesser side effects when it comes to radiation therapy? And the other, you may or may not know the answer to, but one of our viewers wants to know, where in the UK is the other ETHOS machine?
Thank you, Sue. So in terms of does the ETHOS give less side effects to radiotherapy treatment? That's what we're hoping for. So we are still very much in our early days of our journey with our patients and treatment on the ETHOS unit. So we're awaiting outcome data to be able to support that. But as Charlotte said in her presentation, we're able to adapt for treatment, so be able to really hone down on the area, the target that we want to treat, and then aim to minimise those areas that we don't want to give radiotherapy to. And it's those areas that we don't want to give radiotherapy to that cause some of the side effects. So in brief, yes, that's what we're hoping for, to reduce side effects in the treatment. The other question was, where is the other machine in the UK? So that is at centre in Romford in Essex. Thank you.
Thank you, Helen. And last question is, which companies developed the robotic surgery machines? I know that the one that we have are Da Vinci machines. Matthew, I don't know if you know of any other companies that are producing these.
So you're quite right. Da Vinci is produced by a company called Intuitive, and they've had a worldwide monopoly now for a couple of decades. But thankfully, there's a British robot on the market by a company called CMR, Cambridge Medical Robotics. And then the big guns in pharma. So Johnson & Johnson have got a machine out called Hugo, and that's waiting for a CE mark at the moment. So thankfully there's more competition, and for computer assisted surgery, I think the future is extremely bright. In orthopedics, they already have robots called by a company called Stryker, called the Mako robot, and they're really assisting in knee surgery in particular, but also with hip replacement surgery too. So a lot of growth, a lot of excitement coming down the tracks very quickly.
Thank you very much, Matthew. Now, I don't have any other questions at the moment, and I think we are now close to the end of our time. So if any more questions come in, or if during the course of the question and answer session I've missed any, we will answer those questions for you on our website. But in the meantime, I'd just like to say thank you very much to Charlotte, Helen and Matthew, and to the two patients who we featured, Peter and soundly. And I hope that all of you who've been watching this session have found it useful, interesting and informative. And I hope that you will continue with us for the rest of the week and watch some of the other sessions that we've got planned during the rest of the week. Thank you very much for your time this afternoon.